So our next speaker is Dr. Barry Lyons.
Okay, great, thank you. Good afternoon, everybody, and I'd really like to thank Claire for inviting me to speak here today and for organising the meeting, which has been excellent and really thought-provoking. I'm going to talk about something that has already been alluded to a number of times today. So back in 2014, following the death by suicide of Robin Williams, the journalist and author Elizabeth Day wrote an article on stigma and mental health. It started well, if somewhat ironically, acknowledging the media's tendency to invade the personal lives of the deceased. However, it then continued by suggesting that the voluminous outpourings of journalists, bloggers and the Twitterati were sufficient proof that the concept of stigma has no longer got any application in respect of mental health, but rather stigma should be reserved for truly scary incidences of physical decline. So from Day's perspective, what I am talking about this afternoon not only has no relevance, but the linking of stigma and mental health is actually harmful. Unfortunately for the world, Day appears to be incorrect in her assertions. Around at the same time as she was penning her article, a group of researchers at King's College were conducting a systematic review on the impact of mental health related stigma on help seeking. While they identified a small to moderate sized negative effect overall, this impact was significantly higher in particular groups, including healthcare workers. The systematic review provided limited data as an explanation of the higher prevalence of stigma in the healthcare and military communities, but raises the possibility that if we cross-fertilize the high-risk groups, then we might come up with a particularly problem child worth evaluating. And I suppose helpfully some work has been done on one such hybrid, military doctors. And the study I'm about to discuss, the comparison group or groups were ex and current non-medical servicemen. And so compared to comparison groups, military doctors really presented fewer mental disorder symptoms than these other groups. Within the group, there were higher levels of stigmatizing beliefs circulating around mental illness, and there were more negative attitudes to mental health care. There was a greater desire to self-manage, greater self-stigmatization, something that I'll talk about in a little while. And most of the military doctors were particularly concerned about the potential negative effects of and peer perceptions about receiving a mental disorder diagnosis. Those with alcohol or mental health problems were significantly and substantially less likely to seek help than the comparison groups. So when we talk about stigma, what are we really talking about? Typically, discussions around stigma have taken as a point of departure the now classic work of Irving Goffman, a sociologist, who defined stigma as an attribute or undesirable difference that is significantly discrediting, which in the eyes of society serves to reduce the person who possesses it. He contended that stigma is conceptualized by society on the basis of what constitutes a difference or a deviance, and that it is applied by society through rules and sanctions, resulting in what he described as a kind of spoiled identity for the person concerned. Within Goffman's theory, the stigmatized are at risk of being devalued, scorned, shunned, ignored, and ostracized. Those who perceive themselves to be members of a stigmatized group, whether it is obvious to those around them or not, often experience psychological distress, and many view themselves negatively. Anticipated or perceived prejudice and discrimination is associated with poor physical and mental health outcomes. Since Goffman, the number of publications related to stigma and mental health in conjunction indicate that this has become a particularly fertile research field, although it is one that has posed many questions and sadly rather fewer solutions. Within these publications, there are multiple and multidisciplinary theories and definitions around and about stigma. One of the most influential is that of Lincoln PHELAN, which is a somewhat more accessible model than that of Goffman. And it places stigma firmly within a paradigm of power dynamics. Fundamentally, it describes the labeling of human differences that are perceived to be negative or adverse, and the separation of group of individuals who possess these characteristics, a sort of us and them division. Labeled persons suffer anticipated and actualized status loss and prejudice. And so it's unsurprising if people seek to avoid being labeled with a relevant difference, such as a mental health difficulty. What we do know about stigma is that it represents a barrier to accessing appropriate care that impacts upon almost all social groups. This diagram is from a study on young elite athletes. In many such studies, deficiencies in mental health literacy is seen as an important element in producing stigmatization, and thus enhancing literacy around mental health is often seen as a remedy to the issue. However, indeed, stigma resulting in underutilization of services is a particular concern because absent or delayed help seeking may result in poorer prognosis for recovery, increased symptom severity, and greater damage to psychosocial functioning. So augmenting mental health literacy seems like a good plan. However, research on the most literate has shown that mental health professionals, including psychiatrists, psychologists, nurses, and allied health professionals, can also hold negative attitudes towards mental illness, despite having the highest levels of mental health literacy. And in respect of their own mental health difficulties, while mental health professionals may hold positive intentions towards seeking help for their mental illness, this is not necessarily consistent with their behavior. There's a significant tendency towards concealment from colleagues, which feeds into a need and a desire to self-manage. There's also very real concern amongst this group about disclosure within their workplace for fear of adversity or repercussions, and a particular worry that institutions such as regulators may become aware. The fear of disclosure within institutions pervades most studies relating to healthcare professional mental health, as does a sense of significant distrust of regulators who are perceived as likely to hold prejudicial attitudes towards practitioners with a mental health label. This can be seen in this opportunistic sample of US female physicians, of whom just under 70% of those who had not sought help reported stigma-related reasons. This led to a number of particularly troubling behaviors: self-prescribing, persuading a friend to prescribe, seeking faraway or out-of-state providers to avoid anybody knowing, driving out of state to fill prescriptions, and paying in cash. All efforts to conceal the mental health diagnosis. I suppose, like Tara's presentation earlier, qualitative studies such as this one on GPs provide a rich source of how healthcare professionals describe stigma as it appears to them. All of these, I think, are quite recognizable to everybody in the audience about the sort of unwritten rules that there are in medicine. You don't admit to mental illness in any way. Even though everybody knows about it, nobody talks about it. Mental illness is seen as a failure, and we're just not groomed to be ill. We're here not to be a failure, we're here to succeed. And the perception of stigmatizing attitudes of colleagues, which also work as a barrier to seeking help, about the words that they use about the people that they consult with. People just need to pull themselves together. So when compared to the general public, health professionals are often less optimistic about recovery from serious mental health conditions, more likely to believe that an individual with a serious mental health condition would experience discrimination and stigmatization, particularly in the workplace. And even though health professionals profess less stigmatizing attitudes towards people with a mental illness, they share a similar desire for social distance and demonstrate similar or higher levels of self-stigma. And they are particularly less likely to accept a mental health condition in themselves rather than in others. A comprehensive review of relevant research, Corrigan identified 2 types of stigma associated with mental illness that impede seeking mental health care: public and self-stigma. Public stigma comprises the beliefs, responses, and behaviors of other people and how they exhibit those towards the group of individuals diagnosed with mental illness. Public and self-stigma are separate but very related concepts, and I'm going to talk about self-stigma on the next slide. Others have proposed that apart from the stigma associated with the label of mental illness, the stigma associated with seeking professional psychological help, which implies weakness and failure on the part of the individual, also in itself inhibits help seeking. People are likely to avoid or wish to avoid the label of mental illness because of stigma's potential effects on one's sense of self. Living in a culture steeped in stigmatizing images, persons with mental illness may accept these notions and suffer diminished self-esteem, self-efficacy. I seem to have scooted on, apologies. And reduced confidence in their future. People with mental illness often internalize stigmatizing ideas that are widely endorsed within society and believe that they are less valued and less valuable because of their difficulties, and agree with the stereotype. That's right, I am weak and unable to care for myself. Self-esteem is typically operationalized, or the diminished self-esteem is typically operationalized as a reduced view about personal worth and is often experienced as shame. Low self-efficacy and demoralization are associated with failing to pursue opportunities inside and outside work. And obviously these kinds of self-prejudice and self-discrimination significantly interfere with a person's life goals and their quality of life. So in theory, programs that diminish stigma will reduce the attitudes and behaviors that might be barriers to help seeking. Generally, there are 3 approaches undertaken that may diminish aspects of the public stigma as experienced by people with mental health difficulties: protest, education, and contact. Firstly, usually advocacy groups protest inaccurate and hostile representations of mental illness as a way to challenge the stigmas they represent. While protest attempts to diminish negative attitudes about mental illness, it fails to promote more positive attitudes that are supported by facts. Education strategies aim to fill this gap by providing informational fora so that the public can form more informed opinions about mental illness. Unfortunately, research also indicates that the effects of education may not endure over time. And finally, stigma is further diminished when people have contact with individuals with mental illness. And so opportunities to meet individuals with severe mental illness has been shown to be effective in reducing stigma in medical students and nursing students, for example. There are some specific anti-stigma programs designed for healthcare providers. Again, these mostly take the form of contact with trained speakers with lived experience. There are efforts by professionals at myth busting, and also sort of the possibilities of creating facilitated engagements in order to, I suppose, assist people in speaking about their own mental health difficulties. However, there's very little work done on educating or providing fora for managing the stigma that healthcare professionals with mental health difficulties feel in a healthcare environment. Unfortunately, there's limited evidence of the long-term effectiveness of any strategy in reducing stigma. And the question is whether we require alternative strategies for stigma reduction within the healthcare environment. What we do at the moment within this state is that most mental health interventions for healthcare professionals focus on support or well-being programs. They are poorly or not funded at all and generally overly dependent on volunteerism. There's a significant difference between state organizations' verbal cues, such as we really care about the mental health of our workers, and the on-the-ground reality of what is actually provided and funded. There is little effort to evaluate the structural issues that create the stresses and mental health difficulties for workers and the barriers that exist to them accessing appropriate care. And within all organizations related to healthcare, be they institutions or training bodies or medical schools or nursing schools, there's the perpetuation of potentially harmful tropes. The view of perfectionism as something that's good, as opposed to something that is potentially damaging. The reliance on the self-sacrifice of workers to work those extra hours that always seem to crop up. The belief in presenteeism, that you turn up for work regardless of how you are feeling, and regardless of how productive research has shown presenteeism to be. And there's generally in healthcare organizations an inversion of the Twitter hashtag widely used in mental health communities of sick, not weak, but rather of being weak, not sick if you don't turn up for work because you have a mental health issue. So that's it for me. Just an ad for our ongoing Wellcome Trust funded research project on shame and medicine. And if anybody is interested, the link to the website is there. Thank you.
Thank you very much, Dr. Lyons. Does anybody have any questions on the chat for Dr. Lyons? I'm going to pick you actually up on something you just said there about stigma and setting you apart. Do you think then that stigma is kind of like the opposite to belonging?
Yeah, very much so. I think that I suppose one of the things that we know is particularly damaging for people's mental health is isolation, or which can for some people be I suppose accounted for as loneliness, but isolation in and of itself, or being removed from I suppose the groups that we traditionally belong to, is particularly harmful. So stigma is I suppose its real harm is in creating that sense of isolation.
Yeah, and I suppose that's one of the things that has compounded the difficulties with the pandemic is the enforced isolation that goes with it. So it's a double whammy.
I didn't catch that. It broke up.
Sorry, it's a double whammy because not only do you have the stigma and isolation associated with mental distress, but you're also forced to physically self-isolate with the pandemic.
Yeah, our current difficulties, I think, have been really troubling for many people, and I think that most of the earlier speakers have alluded to that. That sense of isolation and loss of community has been really hard on people, and many people.
Great. Well, thank you very much for speaking today.